I'm Dr. Fernandez. I'm working in the cardiology department of La Paz University Hospital in Madrid, Spain. And in the next minute, we are going to review the role of Philips anatomical intelligence in the monitorization of cardiotoxicity in cancer patients. Cardiovascular complications are an uncommon during and after chemotherapy. In fact, there is an intriguing geographic overlap in the prevalence of both diseases. The expansion of cancer therapies to individuals with pre-existing cardiovascular diseases and the improvements in cancer therapies have created a new cohort of patients who will experience sufficient survival to develop the cardiac complications of cancer therapies. The most common cardiovascular toxicity, or at least better recognized, is left ventricular dysfunction, mainly associated with the use of anthracycline and trastuzumab. There is no room for question. In heart failure guidelines, patients receiving chemotherapy should be considered to be on an stage A of heart failure. Recent recommendations propose a new definition of cardiotoxicity. The new terminology is cancer therapeutics-related cardiac dysfunction and is defined as a decrease in ejection fraction of more than 10 percentage points to a value below 53% with 2D echo. This decrease should be confirmed by repeat cardiac imaging in 2-3 weeks and may be further categorized as symptomatic or asymptomatic or with regard to reversibility. Also, several imaging modalities can be employed to identify reduction in EF. Echo is the cornerstone to monitor ejection fraction in daily practice. However, the estimation of systolic function using 2D ejection fraction has several limitations. 2D ejection fraction is heavily dependent on image quality, geometrical assumptions, and reader experience. Measurements are load-dependent, and 2DEF variability is higher than the threshold used to define CTRCD. Of course, the administration of contrast agents improves image quality and reduces quantification variability. But if we really want to be confident with the CTRCD diagnosis, 3D echo is the modality that has shown to be more reproducible for the longitudinal follow-up of cancer patients. However, even a precise EF detects myocardial damage only when functional impairment has already occurred, not allowing for early preventive strategies, and when cardiac dysfunction develops, the probability of complete recovery decreases despite optimal heart failure treatment. We have assessed a phenomenon of the medical community consisting of a rise of awareness on the relevance of a thorough risk assessment of patients that will undergo active cancer therapies. The main objectives of the interventional stage include the identification and control of cardiovascular risk factors, as well as the early identification of cardiotoxicity with specific cardiac biomarkers and new imaging techniques. The estimation of global function using only ejection fraction provides suboptimal data to predict CTRCD. In fact, the heart has an helical structure composed by 3 coordinate layers of myocardial fibers, and ejection fraction only evaluates radial function. Recent advances have enabled clinicians to evaluate left ventricular function using myocardial deformation techniques. Strain is a dimensionless index defined as the deformation of an object normalized to its original shape. Currently, myocardial deformation can be measured using TDI and 2D or 3D speckle tracking echo. 2D strain has several advantages over TDI. It can be obtained in an angle-independent fashion and evaluates all 3 domains of myocardial mechanics using the standard 2D images and with better reproducibility than TDI. Non-uniformity of fiber orientation was matched by a non-uniform susceptibility to injury. The longitudinal component of left ventricular deformation, governed by subendocardial region, is the most vulnerable and therefore the most sensitive to detect the presence of preclinical myocardial disease. In healthy volunteers, the mean value of normal GLS is minus 19.7%, with 95% confidence interval that expands between minus 18.9 to minus 20.4%. Adequate match quality is a critical prerequisite for border tracking algorithm. Of course, it's necessary to take into account that GLS may be also influenced by age, gender, load condition, or vendor differences. However, in this meta-analysis, including more than 2,000 patients, only differences in systolic blood pressure seem to be a source of variation among normal range of GLS. This finding may help to reinforce clinical acceptance of GLS in everyday clinical practice. A growing body of literature supports the use of GLS for the longitudinal follow-up of cancer patients. Despite heterogeneity in data of all the studies, demonstrate that changes in myocardial deformation occur earlier than change in EF and at an anthracycline dose lower than what was historically thought to be cardiotoxic. Also, an early detection of myocardial changes is important. The real value of these changes lie on their ability to prognosticate relevant outcomes, such as EF reduction or the development of heart failure. The ideal strategy is to compare the measurements of GLS obtained during chemotherapy with the one obtained at baseline, allowing the patient to serve at its own control. These slides show the result of the most important studies. Probably the best way to take a look at this data is to use its negative predictive value. If at 3 months follow-up GLS and troponin were normal, the risk of CTRCD is very low. If change in GLS was unavailable, a cutoff value above minus 19% was a predictor of CTRCD. As with many other technologies, automation is the key to achieving workflow efficiency and measurement reproducibility of a strain echo in a busy clinical practice. By using a semi-automatic approach, CMQ has the potential to reduce the variability of cardiac motion analysis as well as a streamlined workflow. After acquisition of 2D images from the 3 routine apical views, 2-chamber, 4-chamber, and lone axis, a CMQ tool must be selected, and we need to confirm the view of each loop to start quantification. The first loop must be the 3-chamber to allow an automatic detection of aortic valve closure and to ensure that we are going to measure the peak systolic strain. CMQ tool detects, aligns, and segments data from volume acquisitions, giving us the opportunity to edit quantification in each stage. The comprehensive summary page report includes a display of left ventricular longitudinal strain in a 17-segment bullseye format as well as the global longitudinal strain. I want to show you an example of how we monitor cancer patients. This is a 43-year-old female with an invasive breast ductal cancer. A treatment with acetaxol was prescribed, and before to start treatment, we perform a baseline echo that shows normal EF and GLS values. At 3 months follow-up, after anthracycline treatment completion, a new echo was performed. The patient complains of palpitation and mild short of breath while exercising. We found a normal EF value, but a significant decrease in GLS. A beta-blocker treatment was started without change in the cancer therapeutic scheme. At 6-month follow-up, the patient remained asymptomatic and the new echo showed a return of GLS to a normal value with normal EF. As a conclusion, CTRCD is an important avoidable cause of heart failure. Cooperation between cardiologists and oncologists is essential to stratify cancer patients' cardiotoxicity risk profile. Careful monitoring of cancer patients is mandatory, and accurate evaluation of left ventricular ejection fraction should be done, and echo is a method of choice in daily practice. Keep in mind these magic numbers: normal EF 53 to 73%, and the diagnostic criteria of CTRCD, a decrease in ejection fraction more than 10% to an ejection fraction below 53%. Because a decrease in EF is a late event, a new approach based on the measurement of cardio-specific biomarkers and new imaging techniques has been proposed to reduce CTRCD and to recognize patients who will benefit from early cardioprotective intervention. The ideal strategy is to assess the percentage change in GLS at follow-up, allowing the patient to serve at its own control. A relative percentage reduction in GLS of more than 15% is very likely to be abnormal, whereas a change of less than 8% appears not to be of clinical significance. Thank you very much for your attention.